Well, thank you very much, Del, for the invitation. So in the next half hour, what I'd like to cover is really the remit of His Majesty's Coroner and focusing on what impacts on us in clinical anaesthesia, the prevention of future deaths reports, and indeed the responses to them. So I'll talk a bit about coronial law and then a bit about tort law, which is where clinical negligence comes into play, and just describe the two leading cases that really underpin the whole business of how we're judged as clinicians if it comes to being sued in the tort of negligence. If a coroner is engaged to commence an investigation, their remit is to establish who died, when they died, where they died, and how they met their death. And this program is still available on Channel 4's Catch Up, and it really rather encapsulates the challenges that coroners have outside the hospital setting, because here was somebody who had somehow become invited to Michael Barrymore's party in 2001 and was found floating in his swimming pool with cocaine levels in his bloodstream, with anal injuries, and how he met his death has to this day never quite been elucidated, as in whether there was a sexual assault and then drugs and thrown into the pool or whatever. So just coming back to perioperative deaths, from my standpoint as a medical examiner, every single perioperative death is not going to be investigated or indeed needs to go to the coroner. And this common law judgment is in fact what our senior coroner is guided by. So if the deceased had a potentially fatal condition and medical intervention did no more than fail to prevent that death, then it was the underlying condition that was the cause of death. But of course, that is contrasted with somebody undergoing a procedure which didn't in any way threaten their life, and it was that treatment that caused their death. So just briefly, the sort of case that Miss Casey and her team have been quite explicit about not being interested in investigating would be the elderly patient with conspicuous frailty, recurrent falls, who sustains a neck of femur, pneumonia, but fades away in the perioperative period, or indeed a stroke, a common NUH workload now, mechanical thrombectomy, decompressive craniectomy. If it's the underlying disease process that neither of these modern interventions manage to forestall, then an investigation generally wouldn't be opened by our coroners. And similarly, somebody has a spontaneous aneurysmal subarachnoid hemorrhage, has an EVD, coil embolization, but it doesn't stop the relentless delayed ischemic deficits, and somebody dies from this aneurysmal pathology. Again, that wouldn't be investigated. But of course, this week, this has just all come to light about TAVIs in Hull, where there's been all sorts of trouble, a series of cases of mortality that was apparently suppressed, and this was all to do with the vascular access of the TAVI devices. And this is very much something where it wasn't a case of a natural disease process running its natural course. So what about reports to prevent future death? So this is where the coroners are empowered to issue these prevention of future deaths, PFD Regulation 28 reports. And the last chief coroner coined this phrase about it is not a badge of dishonor for a trust to receive a prevention of future death report, but what is reprehensible is if there's a failure to respond to it, if it's ignored. And the figures are just out for last year. So there's about 1 every 2 days issued by coroners up and down the country. And of course, I'm just trying to paint a picture of the coroner's service being much broader than what we're concerned with within hospital medicine. So here, for example, the South Yorkshire coroner very, very quickly issued this PFD report about neck guards. Now, I don't know anything about ice hockey, and I don't know of the validity of this, and it did seem rather a knee-jerk reaction to this tragedy. But here was a coroner who long before the inquest has appeared, has stated that she was sufficiently concerned that deaths may occur in the future if neck guards or protectors are not worn. So there's a reflex response from the coroner in whose jurisdiction this death happened. And this was in the news just on Monday, Loudon Grange Prison, where there was attention drawn to the fact that an earlier PFD report from last year hasn't been heeded, and this is all about call bells in prison cells not being have been disconnected just to stop, give the prison staff a quieter life instead of everyone ringing their bells. And so there's clearly the coronial jurisdiction is very much engaged in state detention. So we come now to what has precipitated today's session, and that is one assistant coroner whose jurisdiction is Surrey, East and West Sussex, and Brighton and Hove, who is an anaesthetist to trade. So she has an FRCA, Dr. Karen Henderson. And just as a bit of background, without dwelling on this case, I was involved as her expert in the tragic case of this poor 17-year-old who died following a PPH, and during the transfer from the theatre table to her bed, there was abrupt ventilatory difficulty, and somehow she developed bilateral tension pneumothoraces that were really only diagnosed when the abdomen was reopened and there was a rush of air from the abdomen. And so the reason I'm mentioning this is that here we have a very unusual scenario of an anaesthesia qualified coroner who has picked a thoracic surgical expert to advise on the management of tension pneumothoraces. And he said, of course, the bilateral thoracotomy should have been undertaken sooner, and he believed that this was a failure in the care. So this is in an obstetric theatre where you have a thoracic surgeon who, of course, is opening chests as an emergency, as his bread and butter. And so I did have to make the point that I said this was hindsight bias, and it certainly wasn't barn door obvious. And there were all sorts of confounding issues here in that it was considered at the time to be an anaphylaxis and a reaction to carbaprost. And so this, but I don't want to dwell on this case. It's just the background that here we have an FRCA coroner who is seeking to make her mark on the conclusions of an inquiry. And so this was the case on the South Coast, where the PFD was all about emphasising the 4 T's and the 4 H's, and the response which came from the Association of Anaesthetists and the Royal College was that we will share the learning that bilateral pneumothoraces can be a cause of failure to ventilate, leading to cardiac arrest in the absence of trauma or thoracic surgery. And and they said they were going to do this via the Safe Anaesthesia Liaison Group's patient safety update. And I did last week trawl through all of these and then got in touch with Philip Barclay. And for whatever reason, this has been overlooked. So it never has been shared, which is the way it is. But the case that has led to this morning's session is that of Pamela Marking, who, and this is all in the public domain. Mark Barley has tried to procure for today some more details of the case. I think without a great deal of success. The coroner's officers haven't released any further papers from the inquest. But this was a 77-year-old lady, and there was a backstory here of delayed admission to hospital via ED. Has a right femoral hernia with ischemic bowel. There was an RSI, and as you can read, the cricoid force wasn't applied. There was a nasogastric tube attached to the only suction device, and on induction there was an aspiration, and from which she died. So the PFD has a number of stated problems, and item 6 is a lack of updated national guidelines for rapid sequence induction of anaesthesia for emergency surgery, and this is what Mark is going to dissect in the second part of this hour, and a lack of updated national guidelines to support the use of TIVA for RSI. So Dr. Henderson wrote that other than empirically increasing the rate of infusion of propofol and remifentanil, there was no evidence as to the target range required to ensure and confirm an adequate depth of anaesthesia, and you can read that for yourselves. And also then she goes to town on cricoid pressure, and after aspiration, the only suction device had been attached to the NG tube. So it was really a litany of issues from this case. So the joint response from of 3 bodies on this occasion, the Association, the Royal College, and the Difficult Airway Society, and their worded response is: best clinical practice relies, in addition to available evidence, on careful risk assessment and risk mitigation. In cases where there is a high risk of aspiration, the potential benefits of RSI increase, and thus its use is more rational. And the trust itself has to respond, and they've said that in the setting of bowel obstruction with the increased risk of aspiration, cricoid pressure should have been used. So that sounds sort of more a sort of direct admission of what should have been used. So to turn from coronial law just very, very briefly in the next 15 minutes to the English legal system as a whole, and of course there's legislation such as the Assisted Dying Bill and decriminalising abortion, which is seeking to codify very, very specific aspects of the law. And then what it applies in clinical negligence in England and Wales is the common law, which is judge-made law, where it's decisions of the senior courts, the Supreme Court and the Court of Appeal, that are applied to the lower courts. European Union law is, of course, dimmed out for obvious reasons, and human rights law is very much a political hot potato at the moment, and it does apply to inquest law when there's been a death in state detention. So public law describes the relationships between individuals and the state, and private law is individuals and private organizations. So there's contract and tort being a civil wrong. Negligence is part of the law of torts. And to prove negligence, there's got to be damage for which you're seeking to be restored to where you were beforehand. So, of course, monetary damages or payout will allow you to get back to where you were before the damage. There's the breach of duty, and causation is the nexus. It's what links a breach of duty and what the lawyers will call the actionable damage. And just as an example, something like pain at cesarean section, which is what I see a lot of. Of course, the damage there is psychiatric damage and post-traumatic stress disorder, and that demands psychiatry input to define and delineate the damage. The standard of proof is on the balance of probabilities, meaning it is more likely than not. So that's the standard, unlike, of course, the criminal law, where the punishment is deprivation of liberty. It's got to be beyond reasonable doubt. And the damage has got to be foreseeable. It can't just be anything utterly random that has happened. So something like amniotic fluid embolism, which, although it's got risk factors, is never in a particular case foreseeable. That is something that tends not to succeed in negligence. So the two cases, and you will hear these names of the claimants. Bolam goes right back 70 years to 1954. So Bolam was undergoing ECT in North London. This is one of these typical out-of-town psychiatric hospitals that's now, like Saxondale here, is now sort of affluent residential accommodation. And he underwent ECT with no anaesthetic and was unrestrained on a couch, and he sustained bilateral impaction fractures. And the point is that the expert evidence was equivocal, meaning that at the time it was held that there were all sorts of different ways of doing ECT and people believed different things. Therefore, the judge, and this is the often quoted point here, it's all about and it's all, apologies that it's all gender towards males on the planet. It's what a reasonable man in the circumstances would do. It's the ordinary skilled man exercising and professing to have that special skill. So it's all about having just done it in a reasonable manner that it would be accepted by a responsible body. And that phrase is used to this day. So it's what the OAA would say, or the DAS, as an accepted way of doing something. So you don't need to do something as an outstanding guru at leading in your profession. It's what a responsible body of your peers would do. And then the second case is that of Bolitho, and this is St Bartholomew's in London, and this is about 40 years old. But this was a case that developed Bolam. So Bolitho was a 2-year-old, a toddler, who'd recently had a patent ductus closed. He'd come in with croup and had a couple of episodes where he'd turned white, having got acutely breathless, but he was on the ward running about and he'd had his lunch. And then came an episode where he got acutely agitated, had an arrest with downtime that led to a brain injury, and this was probably all attributable to a mucus plug. And at the trial, at first instance, the expert paediatrician said, well, the only safe thing to do when the child has had 2 episodes of dyspnea was to intubate him. There were clear warning signs. And of course, as every anaesthetist will intuitively know, that that's far too simplistic, because not intubating was what a responsible body would also recommend. And so this went up through the courts of appeal to where the House of Lords said that the court has to be satisfied that the bodies of opinion, the experts, that there is a logical basis to the respective reports, that the body of opinion is responsible, reasonable, or respectable. And I think this is the bit that really comes into RSI. It's comparative risks and benefits, and have reached a defensible conclusion on the matter. So it develops Bolam that was quite simply a judge accepting that, yes, responsible body says it's okay, but this is the court being furnished with the arguments, and it allowing the judge to assimilate these respective opinions. So in clinical negligence, firstly, it's always worth stressing you are found liable, or the trust is found liable. So it's not a case of guilt or innocence as in the criminal law. There are no juries. Very, very few cases go to trial because it costs an awful lot of money for the NHS to lose a case, and they far more often will pay off a claimant with a few tens of thousands of pounds rather than go to trial. And just as a very quick aside, those of you who do independent sector practice, it is much, much more complicated if there's a claim there, because the medical defence organisations, who of course will act separately for anaesthetist and surgeon, and they'll all commission their own reports because they will try and blame each other to try and claw back any damages that are paid out. So it's a field day for the lawyers, because there are counterclaims for contributions to damages, whereas in the NHS, in our trust and every other NHS trust, NHS resolution and the trust legal department will handle the case, and it doesn't really matter exactly which individual might be more at fault than any other. So if we just come to end now, looking at RSI, which Mark is going to take further. So this is, I debated this way back in March 2006 at the OAA, and Tim Meek, who some of you will know, and of course is the current president of the association, he was the traditionalist. And here I was saying that a traditional RSI is an outmoded technique for cesarean section and should be modified. And so in those days, we were talking about propofol instead of thio, that you could supplement with an opioid. And of course, it was Sux versus Rock, but in the pre-Sigamidex era. So it was all based on rocuronium, meaning there was a commitment to ventilate the lungs in a category 1 section, and there wasn't a way back, but it was still a safer construct than relying upon recovery of Sux to get you out of trouble. And then, of course, there's the whole business of cricoid force. So cricoid force, the editorial, which is 9 years old now, by Professor Pandit at Oxford, this I think is pretty reasonable. That apply it, but be very ready to release it, because cricoid force can turn a straightforward intubation into a difficult intubation, and can turn a difficult intubation into a failed intubation. There was a significant error in this editorial, in that they stated, based on a quoted, repeatedly quoted narrative of a case that had never gone to court but had been settled, they erroneously stated that the courts appear to favour the use of cricoid pressure. So I sort of did a bit of fact checking on that, and you can read this if you're interested. But actually, it is not true. This was simply a case that never went to trial, where the expert for the claimant had stated that cricoid pressure should be used. And surprisingly, for an esteemed Oxford professor, they hadn't gone back to the actual origin of a statement that had appeared in one review article and then was re-quoted in another review article. So very, very briefly, of course, we all know this. Selick, 1961, this was a cadaver in the tonsillectomy position, and this was a barium-filled tube in the esophagus. And remember, this was before the era of Photoshop. There are no fingers visible applying the pressure to occlude the barium in the esophagus, and nobody quite knows whether this was a wooden yoke or something that was used to demonstrate the fact that you could occlude the esophagus at C6 if there was pressure applied. And this was, I think, the first of the imaging studies, and this is now just over 20 years old, a Canadian study that told us that what we all had thought we were doing with the application of cricoid force, E is the American for esophagus, we all thought that the esophagus was nicely between the cricoid and the vertebral body, and that pressing on the cricoid would occlude the esophagus. But this CT study showed us that in a significant number of patients, all that happens is that the E for esophagus is displaced to the side and isn't occluded at all. And then John Duggan up in Ashington took a whole lot of ODPs before they became graduates of universities, and it was the British Association of Operating Departments showing that if you actually looked at the pressures that were applied before a training program using a digital means of verifying what 30 newtons of force was, the pressures were anywhere from about 100 newtons to 10 newtons. So really, my conclusion here is that if somebody were to have a go at you for not applying cricoid force, it is a belitho matter about comparative risks and benefits and about what's a logical approach. And of course, it does come back to expert witnesses, and there's a lot being written at the moment. That was David Levy, who ended up in prison and was, of course, freed on appeal. This was in The Guardian just last week, that expert witnesses are the weakest link in the English justice system. And that's, of course, Dowie, Evans and Letby, and there's loads being written at the moment about that case. So what we've looked at today then is coronial law and prevention of future death reports and the obligation of bodies to respond. And we've looked very briefly at where clinical negligence fits in tort law. And Mark found this just last night. This is a pre-publication editorial that our good friend, formerly of this parish, Dr. Wiles, currently editor of Anaesthesia, has just had uploaded ahead of publication, and it's very much what this whole session is about. And so this is rapid sequence induction, a modern day example of Theseus's paradox, and the conclusion. You can read for yourselves, and it's obviously available online as a pre-publication one. But it's really saying that in 2025, anything goes with RSI, and the idea that, as it was when I started, that it had to be unsupplemented, pre-calculated doses of thiopentone, succinylthonium, cricoid force, and that was the only way to do it. We've certainly moved on, and be more than happy to field any questions. So thank you very much.